So first listed code is a condition that is chiefly responsible for the encounter, as documented by the physician. And that first listed code, it can be a symptom as long as there's not a confirmed diagnosis by the physician. Secondary and additional diagnoses are coexisting diagnoses that are treated, they're medically managed, or they have an influence on the treatment of the patient. Chronic conditions may be reported as many times as the patient receives treatment and or care for those conditions. And then history codes may be reported as secondary diagnoses as long as that history condition has an impact on the current care or influences treatment. So maybe an example, patient has COPD as a chronic condition and they're dependent on oxygen. The coder is going to need to pick up that COPD and that dependent oxygen code. Say also for family history, patient presents with chest pain, and there's also a family history of heart disease documented. The coder is going to want to pick up that family history of heart disease as well. So let's test your understanding. Patient presents for outpatient surgery for a torn ACL. They have a left knee arthroscopic ACL repair. Patient also has some chronic conditions, hypertension, CHF, and COPD. Following the procedure, the patient develops shortness of breath. It's determined that that shortness of breath is due to a complication of their CHF, and the patient's admitted to OBS. So which of the following diagnoses would be the first listed code for that OBS stay? You can think about this and pause it if you want before you go on to the next slide to find the answer. Torn ACL is the answer, and our rationale, as we learned per our coding guideline, for the observation status after surgery, it's the reason for the surgery would be first listed followed by that complication code. An exception to this rule, if in the same scenario, if the patient was admitted as an inpatient status, the principal diagnosis would be the reason that was responsible for the admission. And in this case, it would have been CHF. So signs and symptoms, they are acceptable as a first listed diagnosis when an established diagnosis has not been confirmed by the physician. These signs and symptoms should not be coded as a first listed diagnosis when a confirmed diagnosis, of course, is documented by the physician. And then signs and symptoms, as we learned in one of our other scenarios on that pneumonia with the fever and the cough, signs and symptoms that are integral to a confirmed diagnosis are not coded as additional codes. Uncertain diagnoses. In the outpatient setting or physician office, diagnoses that are unconfirmed are not coded. So in the outpatient setting, possible, probable, questionable, rule out are not coded. Only diagnoses that are confirmed. Exception to the rule again is on the inpatient side, unconfirmed diagnoses can be coded. So back to the outpatient side. In such cases, when only an unconfirmed diagnosis is documented as a reason for visit, the coder would need to code the condition to the highest level of specificity at the time of the encounter, which is documented in the medical record. So like your signs and symptoms. So say a patient presented with flank pain and nausea, and they're diagnosed with possible kidney stones. The coder cannot code they can't code the kidney stones because it's an unconfirmed diagnosis. They would go to their signs and symptoms and code the flank pain and the nausea. Abnormal lab tests, they can be coded in an outpatient setting as long as a physician documented the abnormal lab finding. The coder cannot assume a diagnosis just from an abnormal lab finding. So routine lab and radiology testing, the coder should assign a sign and symptom code. They can assign a sign and symptom code that the physician documented on the physician order. In the absence of a diagnosis or sign and symptom, a coder can code V72.5 for a radiology exam or V72.6 for a lab exam. But I really caution using the V codes, these two V codes, as they can result in a denial of a claim when a specific diagnosis is not coded. It is more optimal for that coder to go back and have the physician add a diagnosis to the order.